to thank EHA for inviting me to do this talk. It's very exciting to me to be able to participate in this particular type of session because it is an issue and a topic that's quite close to my heart. These are my disclosures. And one of the things I wanted to sort of talk about as by way of introduction is healthcare generally shifting its focus towards from disease to the patient, and hopefully looking more as patient as an individual or person who happens to have health problems. A meeting between a patient and a doctor is a meeting between two very large extremes, as we've heard repeatedly throughout the advocacy sessions this morning. And a patient and their doctor may have very, very different roles, very, very different languages, expectations, and perspective, as well as their priorities as regards their own health. This particular study was looking at 3 groups of patients, pediatrics, gynae, and internal medicine, and they wanted to see in what respect the communication between doctor and patient was considered balanced in terms of quality of their attention to biomedical versus psychosocial factor. And regardless of the nature of the clinical setting, they were very, very different, with patients being far more focused than their physicians were on the psychosocial issues. So, for purposes of this being a medical conference, when I refer to patient-reported outcomes, I mean health-related patient-reported outcomes. And the Wikipedia definition defines it as a PRO as an umbrella term that covers a whole range of potential types of measurement, but is used specifically to refer to questionnaires completed by the patient. And the FDA draft guidance calls it a measurement of any aspect of a patient's health status that comes directly from the patient without being interpreted or analyzed by a physician or anyone else. So this is all about gathering information from the patient's perspective and specifically refers to self-reporting by the patient, and is gathering patient-specific rather than clinical or other outcome perspectives. So patient-reported outcome measures, or the tools to record patient-reported outcomes, provide composite scores from a series of questions around a central concept to quantify the levels of distress or impairment caused by a patient's symptoms or the disease or the treatments that they have for that. So one of the things is that this is very, very multifaceted. You know, there's the physical aspect, there's the treatment-specific aspects. We've heard about outcomes in clinical trials focusing on outcome measures, performance-free, progression-free survival, overall survival. And then other aspects such as the psychological, social, economical aspects, the impact on patients' finances, potentially they're the main breadwinners of their family, being in hospital, off work, and the financial implications. These can be really quite huge and quite impactful on how someone functions or sees themselves as a person in their roles that they had before their illness. There are lots of different scales in terms of measurements as well. So you can have Likert scales where you strongly agree or you're undecided in the middling ground, or you strongly disagree. The visual analog scale, or a categorized or anchored visualized analog scale where you've got sort of points in between. So there are lots of different ways of doing it, and a variety of patient-reported outcomes have been developed and validated to assess symptoms. For example, tiredness or fatigue, insomnia, constipation, physical, social, and emotional function, and the more complex constructs such as the impact of health on relationships. But the number of patient-reported outcome measures out there is absolutely legion. And picking one for use in a clinical setting or trial setting tends to be, well, we used this in the previous MRC clinical trial, we're going to use it for this one, as an example. But what I really like is the fact that people are still thinking about it. So Karnofsky back in the 1940s was thinking about his treatment using nitrogen mustards in advanced lung cancer and realizing that we also have to measure the impact this has in people's lives, this treatment, this cancer treatment. And rather than just having generic or cancer-specific scales and patient-reported outcome measures, we're also developing more and more disease-specific. So one of the disorders that I spend a lot of time dealing with is Myelodysplastic Syndrome, and the American group has come up with the Prams questionnaire, and the European group have come up with QoL-E. So there are various routes of collection of data as well. Questionnaires, whether you complete it on paper or a tablet or a smartphone, and in young persons or teenage and adults, young adults, completed by a carer or proxy, and patient interviews where the patient can have a facilitated interview with someone, but it's very important for this to be not interpreted by the interviewer. Then you can also have things like electronic and symptom diaries, paper diaries. So the important aspects to be considered in PROMs are reliability. Are the measurements repeatable? Are they consistent? Can they distinguish between changes in response and changes due to errors in administration? Validity, lots of different types of validity. Does it measure what it's intended to measure? Measurements of aspects that are actually important to patients, and the extent to which an instrument covers all the perceived key aspects of relevance and reflects what's actually happening in reality. And responsiveness, this is an issue, this is something that I always find as an issue. So whether a questionnaire takes 10 or 20 minutes to complete, how often are you actually asking the patient to fill this in? Because a lot can happen in 3 months in a patient with acute myeloid leukemia. So actually that in itself is relevant, not just the questionnaire itself. And the practicality, how easy is it to obtain these measurements and administer this and then interpret the output, the scores that you then get. So the ability to detect change is a really important aspect. It's not just the questionnaire, but how often it's administered. And if you've got someone whose disease is changing dramatically from day to day, for example, in acute myeloid leukemia, I've been told today, so up until yesterday, I was wife, parent, walked the dog every morning, was going to work today as usual, but had been feeling a bit tired. Suddenly, that's all gone. I'm going to be admitted to hospital. I'm going to lose my glorious crown of hair, and I'm going to be subjected to stuff that's going to hopefully, potentially, give me a 50 to 60% survival outcome in a few months' time. Great. So from day to day, my life, which was previously nice and ordered, has become incredibly turbulent, and measuring a PROM in 3 months' time probably isn't going to be hugely meaningful. So with myelodysplastic syndromes, for the individuals in the audience who are non-malignant, etc., it's a heterogeneous group of disorders characterized by failure of hematopoiesis and an increased risk of progression to acute leukemia. Median age is in the 70s, so it's a disease primarily of the older individual, and estimates predict increasing prevalence due to an aging population worldwide. There, as we've heard from the previous speaker, there is a very high prevalence of comorbidities in this age group. And there are validated disease-specific quality of life questionnaires broadly incorporated into the clinical trial setting, but very, very limited from my observation of my own practice in day-to-day practice. So the conventional questionnaire-based studies in this patient group, certainly in my patient cohort, where the median age of my clinics for the last 2 months has ranged anywhere from 79 to 85, its physical difficulties are quite high on the list. Visual, cognitive impairment questionnaires are too time-consuming, and I quote that, burdensome to fill out. And for the web-based and online app-based technologies out there, there's a perceived lack of familiarity or engagement in web-based surveys in this age group, whether that's true or not. So, as an example, there was an online survey in the UK of 1,725 members of public affected by blood cancers, of which there were 1,725 respondents, just over 1,000 of which were actual patients. The rest were carers or people whose lives were impacted in some way by cancer. Only 4% of these individual participants were affected by myelodysplastic syndrome. So this is a group of individuals that can be quite hard to engage in studies in patient-reported outcomes and day-to-day. So this is just an example in two halves of the hospital anxiety and depression scale. And it talks about symptoms that primarily talk about tiredness, fatigue, anxiety, feeling low, not enjoying things, not seeing the funny side in life, losing interest in appearance, and that sort of thing. The higher the score, the worse you're doing. And this is where we came across some, thanks to the MDS UK support group and their phenomenal networking capabilities, a particular technology which has already been trialed in various different settings, such as detection of autistic spectrum disorder, where the p-values for that were phenomenally high, coronary artery disease, and detecting a significant difference between the voices and voice spectrums of individuals with and without disease. So we've got lots of technologies out there, like OK Google and Siri. You can interpret what you're saying, put it down, and then analyze what it is you want and do it. So book a hair appointment, for example. So the voice is a new paradigm in the human-computer interface. It's estimated by 2020, 50% of all searches will be done by voice. So this digital artificial intelligence makes collecting and analyzing vocal data quite a lot easier than it was even 5 or 6 years ago. This emotion AI engine, through voice, it can detect arousal, temper, valence, various mood groups. And what I found particularly interesting about this technology was it had already been trialed in various different settings in over 40 languages, and claimed to be culture and language agnostic. So those of us who live in Sheffield with a broad South Yorkshire accent, this technology seems to be able to have no problems interpreting what you're saying, Glaswegian accents, etc., all good. And I know I can have some difficulty with some of those accents as well, personally, having lived in the UK for more than 20 years myself. So what this technology would do is transform voice intonations and look at vocal biomarkers, passive, continuous, non-invasive, and very cost-effective. It's an app. It's a telephone call. And what would happen is that the voice qual meter, which we'd like to call it, will take 3 recordings, taking no more than 30 seconds each. So in a minute and a half, you're done. The technology can send a reminder to you once a week. So this is a weekly qual recording, a neutral text reading, positive emotional event, a negative emotional event, with prompts to make suggestions of what these could be. And this is deliverable by any technology which can do voice plus a recording. So telephone, tablet computer, smartphone. And the solution architecture would basically mean you talk into these bits of technology, the voice gets analyzed in real time, and then there's a specialized overtime analysis by very high technology, very highly skilled individuals who deal with these recordings and come up with the vocal biomarkers and a scoring system that's then fed back both through the app and to the medical team. Very, very excited to be working with the MDS UK Patient Support Group, the University of Sheffield, where I'm an honorary senior lecturer, and Sheffield Teaching Hospital to be setting up a pilot study of 30 patients. We are asking a lot of the first 30 patients on watchful waiting, because I do think that this particular group of individuals with myelodysplastic syndrome are kind of marginalized. Here's a bump of information, off you go, we'll see you in 3 months' time. And basically, this particular group of individuals will have to fill in a lot of concomitant questionnaires that's going to be administered randomly, because we don't want the same sequence of questionnaires to be given out to these individuals to get questionnaire fatigue. And that will be correlated against the information that we get from the voice qual meter concurrently will be compared to see whether this could form a preliminary, very preliminary data set. But we're basically looking through the logistics of delivering this technology day to day and whether it actually sort of does what it says on the tin. And as per any study that's looking at a particular disease group, we will, of course, collect demographic and biological data as well regarding Myelodysplastic syndrome, blood counts, and age, etc. So we would really like, in an ideal world, to see whether we can improve or get very high participation rates with patient-reported outcome measures in day-to-day practice in patients with MDS, and potentially do this as well with the paper questionnaires by improving the access to them. Can we facilitate it by reading it out to them via telephone, verbally administered questionnaires face-to-face, or via telephone, online, or postal? And with the pilot study, we very much hope to establish the optimal combination of questionnaires to inform this multi-center study, with the preliminary validation data set for the voice qual meter, and to establish whether this provides additional value to individuals in the clinical team, provided we have the additional supports available to these individuals. Lastly, I'd like to acknowledge MDS UK, Sophie Wintrich and Manuela Rothstein in particular, and our collaborators in this study so far.